Hello and welcome to Insights Care, a #1 preferred healthcare magazine in India and across the globe, leading with a vision to be a one-stop for exploring the world of care for individual and a group. And with us today we have a very inspiring personality who have not only paved new historic innovations in the world of healthcare but have also inspired millions of people across the globe through his learnings and experience. Please join me in welcoming Dr. Vikas Leelavati Balasaheb Jadhav.
Thank you.
Sir, we are honored to have you here. To give you all a brief, Dr. Vikas is a clinical research scientist and a super specialist in gastrointestinal tract sonography. With his extensive experience in gastrointestinal tract ulcer diseases, his dedication to improving patient outcomes and pioneering non-invasive techniques have earned him recognition in the medical community. Dr. Vikas, your work has significantly inspired the lives of many. Could you please share us some insights into your journey and the innovations you have pioneered in your field?
Later during my practice, when I started my practice in 1995, I remember one particular day, that is 18th January 1996. One patient came in the afternoon for abdominal sonography. He was having postprandial vomiting, and the surgeon sent that patient to me for sonography of the pancreas. He was having a doubt about whether this patient is having pancreatitis, which is leading to the postprandial vomiting. Then I scanned that patient on sonography, but I could not see the pancreas because the overlying stomach was full of food and fluid residue. Then I asked the patient to come next day morning, NBM, kneel by mouth. But next day morning 9:30, that patient came and the scenario was same. He was still having the food and fluid residue in the stomach. Then I asked the patient, I asked you to come kneel by mouth, why you came with the food? He said, no sir, I had food yesterday afternoon before coming to you. After that I haven't had anything. Then I thought, why his stomach not emptied in the scheduled time? Because stomach should empty in a couple of hours at the max. Then that was my first case of chronic duodenal ulcer causing gastric outlet obstruction. So that was my first case of chronic duodenal ulcer. The ulcer was causing smaller, thickened duodenum, first part of the duodenum, and which was leading to outlet obstruction. I traced that patient afterwards, and that patient went to the gastroenterologist. He performed the upper GI endoscopy, and he confirmed that yes, this patient was having gastric outlet obstruction due to chronic ulcer disease in the first part of the duodenum. Then after that patient, I have a habit to look for the book in for every interesting case, but after this case I couldn't find any not even single paragraph which shows that ulcers can be seen on the ultrasound. Then I thought I should explore stomach and duodenum each and every patient. Then I started to exploring stomach and duodenum each and every patient. Then every patient I used to take the follow-up with the gastroenterologist, and I was carrying my ultrasound findings, images and report, and go to the gastroenterologist who has performed the endoscopy of the patient whose sonography has been performed by me. Then he was teaching me that you said the ulcer is here, but no, there is no ulcer. You said the ulcer along the anterior wall, no, it is along the posterior wall. Just because I was not having any textbook to learn the ulcers in the gastrointestinal tract, I have to learn through the feedbacks. Then for this learning, I attended more than thousands of endoscopies and surgeries just to get the feedback.
Okay.
That's all.
So the second question is, as the world's first PhD holder in ultrasonography of gastrointestinal tract ulcer diseases, what challenges did you face during your research?
I just it is the same that the demonstration of ulcer disease using any imaging modality or sonography is not included in any textbook across the globe yet. So it was my habit to go to take the feedback, get the critics from the gastrointestinal tract physicians and surgeons about my findings, and then to update me that ulcers can be diagnosed on the sonography.
Okay, nice.
And this helped me to update myself and to develop Dr. Vikas Jadhav's ultrasonographic and imaging classification of the ulcer disease in the gastrointestinal tract.
So that is how you learned. Okay, nice. Okay, so we would love to hear a success story where your early detection method significantly changed the course of treatment for a patient.
Oh, good. Very interesting question. And I remember one case that case was very much challenging. I remember every details because that case was very famous during that time in 2009. One 69 years old male, he was in UK with his son, and on 5th August 2009 he had a severe epigastric pain in the midnight, and he got pulseless and unconscious. Fortunately, the ambulance was nearby. The ambulance came, the patient was revived inside the ambulance, and they took him to the hospital, and they performed the immediate contrast CT scan, which showed that the patient was having a retroperitoneal mass, which is involving major vessels, aorta, IVC, SMA, SMU, and both renal vasculature. It was extending from the right renal hilum to the left renal hilum. It was quite big, 25 centimeter mass lesion. On 17th August, on the day of discharge, the same CT was repeated with contrast, and the diagnosis was confirmed. It's an inoperable malignancy that it is involving all major vessels and both renal hilum. As it was an inoperable malignancy, the patient came back to India to eminent gastrosurgeon of the Pune, Dr. Gajanar Vagolikar. He referred that case to me for a biopsy to check the pattern of the malignancy. I took him for the biopsy. Before biopsy, I performed sonography and found, oh, it's not a malignancy, it's not a cancer, it's just a huge hematoma. I mentioned that in the report. Dr. Vagolikar was agree with me because he was well versed with my sonography reports during the last decades. Then he suggested that we should have a concrete evidence. So we decided to he decided to undergo for the CT scan again, because UK people, they don't issue the films, they issue only reports. Then the patient underwent CT scan with contrast, and I requested the CT reporting radiologist to report it as a hematoma. They said yes, on ultrasound it looks like hematoma. But when they performed the CT, they came to me and said, no, it's an enhancing mass lesion, we can't report it as a hematoma, it's an enhancing mass, so it goes in favor of malignancy cancer. Then the Dr. Gajanar Vagolikar mentioned to the patient that I believe in Dr. Jadhav's reporting, and it's better not to do anything. Then the patient went to another 2 hospitals, and the CT were reported one more time, and every report was saying that it's an enhancing mass lesion. And nobody was listening to me because I was my sonography findings were exactly opposite to the 2 CT reports from the United Kingdom and 2 CT reports from the Pune. Then I approached the patient. I said that I requested him to give me a month so that we can solve that issue without any surgery. He said, no, we have been offered surgery, but the table death consent has been asked, so we are thinking on it. I requested him, give me a month. Finally, he agreed to my intentions, and then I requested Dr. Vagolikar to start medications on the hematoma. He started the medications, and after that I asked him to come for sonography follow-up sonography after a month. After a month, I found that the mass which was earlier 25 centimeter was regressed to 22 centimeter, and the patient was also feeling better, and he is developing faith in me. And I just mentioned him that yes, we are on the right track, just come for the sonography for every month. And after, to be straight, after 6 months sonography every monthly, the whole mass was gone, as it was not a malignancy, it was a hematoma. Then the latter in this was in 2009, and in 2016 Lata Mangeshkar Didi called me up and she congratulated me on this case.
Okay, nice. Congratulations.
Thank you.
Coming on to the next question. Your method has potential life-saving implications, especially in predicting impending perforations in gastrointestinal ulcers. Could you please elaborate on the importance of early detection and how your system improves patient outcomes?
Very good. Acid secreted in the stomach can destroy the inner layers of there are two barriers. One is mucosa and another is muscularis externa. Mucosa is a chemical barrier, and muscularis externa is mechanical barrier. When there is an imbalance between the acid secretion and the mucin secretion, then it causes erosion of the mucosa, and initially the mucosa get eroded and then it goes into the deeper layers, that is mucosa, submucosa, muscularis externa and serosa. When it reaches to the serosa, it will cause an impending perforation, and after serosa it is a perforation, frank perforation. So on sonography, when you see the all 5 layers very well, you can measure the width of the ulcer and the depth of the ulcer, and if the ulcer is reaching beyond or at the muscularis externa, which is the strongest barrier of the gastrointestinal tract, then it is supposed that it is going to perforate. So it's an impending perforation, and when it reaches beyond the muscularis externa, it easily erodes the serosa and it becomes an ulcer perforation. So in my classification, type 2, type 4, type 5 and type 6, these are the stages where you can see the depth of the ulcer. You can predict whether the ulcer is reaching to the deeper layers and leading to the impending perforations. If it is reaching to the muscularis externa, then we suggest the clinician to conserve this patient very aggressively, so that it should not go to the perforation level.
Okay.
That's all.
How does your sonographic method differ with traditional imaging techniques in terms of speed, accuracy and patient impact?
For this, I think type 7 is the best example. Type 7 is ulcer which in type 6 the ulcer is already perforated, and in type 7 the ulcer perforated, but it is naturally sealed by the omentum. Omentum is nothing but an abdominal fat which is also called as the policeman of the abdomen. When there is something wrong in the abdomen, the omentum goes and patch up there. So it is called as the policeman of the abdomen. When the ulcer is perforated, then if on sonography, if you find that the fluid and air is not leaking just because the omentum is patched there, at that time, even though the patient is having everything to go for immediate surgery, that is ascites, pyoperitoneum, pneumoperitoneum, guarding, rigidity, severe pain, if you find on sonography they will know the ulcer has been perforated, naturally sealed by the omentum, then you can avoid the surgery and the patient will get better without surgery just by good conservation.
Okay. Please elaborate on type 8 reverse ulcer diseases of your classification.
Wow. This is the most beautiful classification of my, most beautiful type of my classification. I remember one case, one lady, I think she was a 41 years old female. She was having abscess in the left lobe of the liver, and I told that you get admitted and we will perform the basic investigations like PTINR and platelet count, and if everything is okay, then next day I can perform ultrasound guided aspiration of the liver abscess so that the surgery can be avoided. But that patient didn't turn up to 4 days. 5th day she came, she was feeling better, she was insisting me to ask the surgeon to discharge her. I told her that let me have a look at. On the day one, the abscess quantity was around 80 cc, and when I scanned her on 5th day, the abscess quantity was only 10 cc with some air bubbles within. Then I asked her whether anyone has put a needle inside and aspirated the abscess. She said no, nothing has been done by anyone. Then I thought where this abscess has been gone. Then I found the abscess initially perforated through the liver, left lobe of the liver. The abscess, which is itself is irritant, it has irritated the liver capsule first. Then the liver capsule got broken, ruptured. Then immediately there was a serosal outer layer of the stomach which was adjacent with the left lobe of the liver, that has eroded the serosal layer, then muscularis externa, then submucosa, and then mucosa. So the ulcer has started from the outer layer and then perforated inside the gastric lumen. So it is just like that the God has drained her abscess naturally, because the abscess which was in the left lobe of the liver got perforated into the gastric lumen. Then I asked her whether she had any episodes of loose motion. She said yes. On the day 2 she had a loose motion, just because the abscess which was inside the left lobe of the liver got perforated into the gastric lumen, and that causes reverse osmosis, and the body has flushed the stomach with the fluids, and that started her loose motions. So that was my that strikes me that this is a reverse ulceration, and we can also set subtypes for the superficial ulcer, which is along the outer layer, that is serosa. If it is beyond the muscularis externa, which is the strongest layer of the gastrointestinal tract, then it is called impending perforation, reverse impending perforation. And the third type, when it goes inside the gastric lumen, it is a perforated, reverse perforated.
Okay. So how does type 7 and type 8 differ?
Type 7 is ulcer perforation from inside to outside, and type 8 is ulcer perforation from outside to inside.
Okay.
This is never mentioned in any textbook, anyone in the world.
You have discovered
yes.
it. Okay. Okay. How do you see the future of gastrointestinal imaging evolving, particularly with advancements in technology and research methodologies? Also, what role do you believe collaboration plays in advancing research and clinical practices within the field of gastrointestinal sonography?
Yeah, I would like to mention the difference between the artificial intelligence used in the field of radiology. Artificial intelligence right now it's going very well with the static studies like X-ray, CT, and MR. But ultrasound being a dynamic study, the AI is not yet attempted in this. Then I feel if I make the dynamic study into the static study, like see, initially when the ultrasound was started, that time it was a static study, and then it get converted into the dynamic study. But if we can take it back to the static study, then it can be repeated it can be performed like a CT scan or MRI, and then the AI can be applied. So I'm trying to fit or say merge my research of the Dr. Vikas Jadhav sonographic and imaging classification of the ulcers in the gastrointestinal tract with artificial intelligence and machine learning by converting this dynamic study into the static study to be used worldwide in shorter duration of time, and more accuracy can be achieved using the artificial intelligence and machine learning. But for this, biomedical engineering IT industry will play a pivotal role in converting the dynamic sonography study into the static sonography study like X-ray, CT and MRI and then it will be used worldwide in a shorter duration of time.
Okay, so your answer led me to a question. What do you think is artificial intelligence, machine learning or robotics is a threat to healthcare, or it is lending a hand?
No, it's not at all threat to healthcare. It's initially when the ATM machine came, then credit card, debit card, we have to get well versed with the advancing modality. Then if you get expert in that, then it is not a threat.
Yes. With recent advancements, I recently read an article in Pimpri Chinchwad. There was a live liver transplant plant.
Yeah,
robotic.
I'm in that team.
Okay.
Yeah,
I read that article. It was quite impressive how healthcare is evolving now. Okay. Could you please elaborate on some of the key skills and qualities that are essential for success in clinical research and gastrointestinal tract sonography?
It is basically to get well versed with the gut signature, which is very essential for any diagnosis in the gastrointestinal tract, ulcer disease or any diseases in the gastrointestinal tract. You have to well versed with the gut signature, that is 5-layer pattern I mentioned you earlier. And to teach this, I have started a fellowship course in the gastrointestinal tract radiology, first time in India, and the fellowship course in gastrointestinal tract mucosal lesions on sonography, that is the first time in the world at Dr. D.Y. Patil Medical College, Pimpri, Pune.
Okay. As a leader in healthcare, what message would you like to convey to those entering in the field regarding innovation and patient care?
Yeah, related to gastrointestinal tract sonography, see, the intestines are pretty long. The small intestine ranges from 18 feet to 22 feet, and that is fitted inside our abdomen, and the large intestine are around 6 to 8 feet. So, and these intestines are having peristalsis. They are filled with fluid, then stools and food and everything that goes inside our stomach. So on sonography it becomes difficult when the air is more in the lumen, so you have to wait for the peristalsis so that the air moves further and you can have a look at that particular bowel loop. So patience is very important in the gastrointestinal tract sonography, and the firmness in your findings. Just like I said, that there was a big hematoma which was not seen on the CT scan. The CT was mentioning it's a malignancy, but I was firm that it's a hematoma.
Okay. As someone who has achieved such significant advancements in medical field, how do you balance the intense demands of a professional life with your personal?
It's pretty difficult, but if you keep your humor alive inside, then
yes,
then you should enjoy what you do, then it's easy.
Okay, so
Bonus question.
So this is a bonus question.
Very good.
So considering your 30 plus years of experience and you have visited to 30 countries, delivered speeches to Indian and international conferences. So I wanted to know what keeps you moving forward, or what inspires you to keep moving forward, and what it teaches you?
Actually, this credit goes to my gastroenterology mentor, Dr. Rajesh Dharamsi. In 1999, he mentioned that what you report, nobody reports in the world. So better you write a paper and submit it. Then I submitted to in Indian Congress, but it got refused. Then he asked me to submit to the international conference, and in international conference it got accepted. In AOCR, in Asian Oceanian Congress of Radiology, where Asia, Australia, New Zealand and all these countries are participating. After that, this first conference was in March 2000. Then in September 2000 there was one more conference, big conference, ICR, International Congress of Radiology, that was held in South America, Argentina, Buenos Aires. I submitted the same paper for the oral presentation over there. That was a 10-minute paper, and out of that 8 minutes will be for the presentation and 2 minutes for the question answers. I sent my paper on email, and they replied that, oh, this is a brand new topic, it is not in any textbook, so we enroll you as a faculty. And I was the youngest faculty in that conference, and my immediate senior was 15 years elder to me, because at that time my age was hardly 29 years, and I was the youngest faculty in that conference. And since then I become a faculty to every Indian and international conferences.
Thank you for your time and sharing your journey with us, and we look forward to staying in touch and
Sure.
hopefully collaborate in the future as well.
Sure.
Thank you.
Thank you.